Hello guys, I'm doing this video because a lot of you guys had concerns with EKGs. Now I'm doing this on the fly, did not prepare anything, and I'm doing this mostly to help you guys out. I'm right now studying for my shelf exam. Hopefully a little break won't hurt me. So anyhow, with EKGs, the main thing you need to understand is what is an EKG. An EKG is an electrical signal, in which case you want to look at the heart and how the heart propagates signal. Now, again, this is on the fly guys, so pardon my poor penmanship and using one hand here. So this is my rough rendition of the heart. So you have the SA node, which is the first one to fire. The SA node goes to the AV node. The AV node then goes to Purkinje fibers, or it goes to a bundle of His. Then it goes to the Purkinje fibers, and then it goes to the rest of the heart. So now, if you guys can see, the general pattern of this is usually in a diagonal method, and this is the normal axis deviation. If this is a person's arm right here and right here, this will be their left side, this will be their right side, okay, and this will be the foot area, okay. So as you can see, we have a propagation of signal that goes in a diagonal area. Now why is this important? Well, it's important because it goes with the heart anatomy. When you want to look at the heart anatomy, you want to understand is when you look at EKG, what is the EKG telling you about the heart anatomy? And I'll go more in depth on that in just a minute. Anyhow, you have your SA node going to your AV node, from your AV node to your bundle of His, from your bundle of His to your Purkinje fibers, all in what is called a diagonal fashion, which is, in this particular case, we're talking about our normal axis deviation. Now, what happens if this part of the heart becomes thicker? Well, in this case, you have more electrical conductance in this area of the heart. More electrical conductance means that the axis of deviation is going to shift more towards the left. Remember, this is the left over here. So this is what causes a left axis deviation. And again, remember, an EKG, all it is showing you is electrical activity. I'm going to be talking how we get electrical activity, left axis deviation, normal axis deviation, right axis deviation in just a minute. Now what if you block the electrical signal here? Assume there is a complete block here. Well, you're going to have what's called right axis deviation because you're blocking the electrical signal. Another way you can have a right axis deviation, again, remember, if you have hypertrophy over here, you have thickness of the muscles over here, and you're going to have more electrical activity here. So one thing that could cause a right axis deviation is a left bundle branch block or right ventricular hypertrophy. On the corollary, what will cause a left axis deviation is a left ventricular hypertrophy or a right bundle branch block, because you're blocking, if you have a right bundle branch block, you're blocking the conductance over here, so you're going to have the electrical signal goes more towards the left. Normal axis deviation is where everybody wants to go to. However, pathology means a disease state, will cause left ventricular hypertrophy or right ventricular hypertrophy. Now, how do you determine if it's left or right ventricular hypertrophy? Well, that is where you need to know about your leads. Okay, but before we talk about your leads, I want to talk about some anatomy. When you have your heart here, you have the anterior portion of the heart, okay? You have two coronary arteries. You have your right coronary artery, your left coronary artery, so this could be left, this could be your right. Your left coronary artery gives rise to the anterior descending artery, so anterior descending artery, okay? And then you also could have your circumferential artery, okay? Left circumflex artery. Then you have your right coronary artery, which in 80% of the individuals give rise to what's called the PDA, posterior descending artery, okay? Posterior descending artery. Well, why is this important? Well, whenever you have blood supply is what's going to be giving oxygen to our muscles. Without oxygen, our muscle dies. So in this particular case, if we have dead muscle tissue, what's going to happen to electrical conduction? Well, if you have no muscle to conduct electricity, you're essentially SOL. So in this particular case, you have your coronary arteries, and all this could be seen with your EKGs. Now, in a nutshell, these are the current pattern, and I'll try to upload a picture on the Facebook page. Lead 1 is going to look at the lateral part of the heart, so we look at your left circumflex artery. Lead 6, V6, is going to be also looking at this. You're also going to be looking at AVL, AVL for left. Okay, so AVL is also going to be looking at the lateral part of the heart. When you want to look at the posterior part of the heart, aka the PDA, you're going to be looking at leads 2, 3, and I'm also going to do it here so that way when you guys look at the circles, it'll be easier to see, and AVF. AVF stands for foot. Okay, so AVF stands for foot, L stands for left, and AVR, okay, AVR stands for right. So this right here gives us a vague familiarity of what to look for. Now, if I have pathology, or if I have a problem with these leads right here, that means I have a problem with the left coronary artery. If I have a problem with leads 2, 3, and AVF, I'm looking at a problem with the posterior descending artery, which on 80% of the individual comes from the right coronary artery, which is part of the, again, which gives rise to the PDA. Now, if we're talking about the front part of the heart, and the front part of the heart is very important because the PDA, as you probably remember from anatomy, only supplies 20% of the septum. If you're going to have an MI, an MI is a myocardial infarction. A myocardial infarction is a heart attack. If you're going to have a heart attack, you want it to be in the PDA. You want complete occlusion of the PDA because it's only 20% of the septum. I'd rather lose 20% of the septum than lose this guy right here, which is the anterior descending artery, which is going to be a total of 80% of the septum. And this comes from the left coronary artery, okay? Remember, this is the left, okay? So in this particular case, these leads the anterior leads could be done by using what is called your V lead. V1, V2 look usually at the right ventricle. V3 and V4 are going to look at the septum, which is where this anterior descending artery looks at. And then you have your V5 and V6, which is going to look again at your lateral part. So this will also be V5 as well. Okay? Which will be looking at your lateral part, which is your left circumferential artery. So this is more or less a quick thing of what the different EKG looks at. Now, why don't we talk about pathology, and we'll come back to this in just a minute. So there are a couple things you need to know when you look at EKG. You have your P wave, Q, R, S, and then your T wave. Now, Q waves are usually only seen when you have an old MI. So this is usually, if you see a Q wave, it's an indicator of an old myocardial infarction that has been resolved. This right here should be the size of one box, which, if I recall correctly, one box is 0.2, I believe, milliseconds of something. Now, when you look at this over here, if it is elongated, you have what's called a heart block. You could have a heart block is when you have a block that is prolonging the signal from one electrical conduction to another. Now, in this particular case, you have what's called an AV heart block. If they are equal, you're going to have what's called a first-degree heart block. And this usually just causes bradycardia. And when it causes bradycardia, it's usually benign. You don't need to treat it. But this is really, the heart blocks, you're going to be learning on a different lecture. I'm not even going to worry about the heart blocks now. It's relatively easy to follow and very easy to do. The most important thing that we want to look at EKG is what's called ST changes. So an ST change is when you have either a depression in your ST segment or when you have an ST elevation. ST elevation is indicative of a myocardial infarction. ST depression is usually ischemia. Now, for a matter of simplicity, when we're talking about MI, we're talking about complete occlusion, 100% occlusion of an artery. So if, let's say, we have, going back to our anatomy here, leads 1, V6, V5, and AVO has ST elevation. So we're talking about these leads having ST elevation. We're talking about complete occlusion of the left coronary artery. What this is telling us is that the left coronary artery is occluded 100%. So now the muscles over here are starving. It doesn't have oxygen, and so they're dying. If, let's say, I have leads 2, AVF, and 3, if, let's say, leads 2, 3, and AVF has ST depression, what we have ischemia. Now, ischemia is not completely starving oxygenation to the, in this particular case, but these are look at the posterior part of the heart. We're looking at the posterior descending artery, okay? Remember, these leads look at posterior descending artery. It means that this has about 80% occlusion, okay? So there's still some blood going through. There's still some oxygen providing to these muscles. However, of long strenuous exercise, you could start having chest pain, and that's what we call angina. If you have angina, and angina is stable, then that means that it is only caused, or is that actually worsened by exercise. If you have unstable angina, it means that you constantly have chest pain even if you're at rest. Stable angina is if you have chest pain only when you exercise, and you have unstable angina whenever you have pain when you're not at rest. I mean, even when you're at rest. So unstable is when you have pain even at rest. Okay? So that is more or less what you want to look at when you're doing EKG. You want to look at the different leads, and you want to look at the pathology of the leads to show you what's going on with the heart. Now, let's say we actually have elongation in the PR interval. So the PR interval is right here. Let's say we have an elongation in this PR, we have a heart block. Let's say we have an elongation of the PR interval between leads 2, 3, and AVF. That means we have a heart block that is particularly propagating in the posterior part of the heart, which means that the posterior part of the heart here, you have a slow propagation from the SA node to the AV node, okay? So you have a slow propagation from the SA node to the AV node in the back part of the heart. Now, one thing I probably jumped the gun was I assumed that you guys knew what these different guys actually meant. So this right here is your P wave. The P wave is your atrial contraction, okay? Atrial contraction. This right here is your QRS. QRS. Your QRS is your ventricular contraction. And this right here is your R wave, which is your ventricular relaxation. Now, here we have a relaxation of the ventricle, but we don't have a relaxation of the atrium. Well, that's not true. The relaxation of the atrium is actually located right here, but because the QRS has a higher, I will say, has a higher voltage, it actually masks. Again, remember, these are measured voltage, but we're looking at the electrical signals to the heart. Because the QRS has a higher voltage, the depolarization of the ventricle has a higher voltage, it actually masks the repolarization of the atrium. So in a nutshell, this is what you want to do when you're looking at EKG.